All right. Good morning, everyone. So nice to see so many of you today. I'm going to give folks another minute or two to get logged in, and then we will go ahead and get started. Andrew, if you want to try sharing your screen to make sure it works, I think you should be able to. Perfect. Yes. All right. It looks like the amount of people getting logged in has slowed down, so we'll go ahead and get started. Good morning, everyone. I am Erica McAllister with the Nevada Health Authority. I'm the School Health Services Liaison, and we're here today to focus on the role of community health workers in schools, presented by Andrew Pham with the High Sierra Area Health Education Center, or AHEC. And he has a presentation, and then there will be time for questions. But if you have any questions during the presentation, you may raise your hand or put them in the chat, and we will call on you and get those questions answered. All right. Pass it off to Andrew.
Hey, thank you, Erica. Hello, everyone. Good morning. My name is Andrew, as Erica had introduced me. I'm with High Sierra AHEC. We are a local nonprofit here in Reno, Nevada, dedicated to continuing healthcare education for students from the high school level all the way up into their graduate studies. And one other program that we are deeply ingrained with is the Community Health Worker Certification Program for the state of Nevada. As one of the authorized and certified community health worker trainers in the state, we have trained over 400 students to become community health workers in the state of Nevada, and all of them have found some form of employment, either with state, local, or nonprofit or private entities. Um, it really depends, and it's really nice for this whole field because community health workers as a whole can be employed in a vast number of different settings, and one of which is in the school setting. So, just really quick, again, we're a nonprofit organization. If you'd like to check out our website, it is www.highsierraahec.org. You can find more about our programs and what we offer. If you have any questions on that, after the presentation, I'd be more than happy to drop the link into the chat. So, what is a community health worker? First and foremost, community health workers, they are the liaison and link between the necessary health and social services that a community needs to be healthy and to maintain their way of life, and the community members themselves. The I guess unique thing about a community health worker is that they are someone who is really ingrained with the community and they live in the community that they serve. So one huge thing that we have in Nevada and frankly in the entire country as a whole is we have a healthcare workforce that are mainly comprised of transplants going to where there are opportunities. And while there is nothing inherently wrong with that, the challenge from a healthcare workforce pipeline development standpoint is we have all this local talent that, for one reason or another, will not stay with their local community. and that local community loses out on a community member who understands that community on a fundamental level, right? From culture to the unique health challenges that the community might face. That knowledge and that lived experience is lost. So, with community health workers, what we try to really emphasize and what really this field emphasizes is keeping that local workforce, well, local, keeping that person within the community so they can continue to serve the community they live in. With the state of Nevada, there are many other titles that a CHW can inhabit, and it really depends because community health workers take on so many roles, and it really depends on who is employing them. They are advocates, educators, counselors, and they also can facilitate culturally competent service delivery depending on the needs and requirements of their employer and the community as a whole. So, as I alluded to a little earlier, there are a lot of things that a community health worker can do, but if you want to distill it into four main categories, you can summarize them into outreach, education, coordination, and advocacy. As far as outreach is concerned, community health workers, being local members of the community that they serve, are intimately familiar or should be intimately familiar with the different services that are available within any given city or town or local township. So with the community health worker, they can basically conduct outreach to these community services, so libraries, churches, human services offices, and other different services that someone may not be aware of if they're quickly moved into the city community, or say they have lived here but were not familiar with what was available at the time. So the reason why this is important is because CHWs can determine, okay, based on the social determinants of health found in their community, they can connect their neighbors with different resources like the Reno Housing Authority or a local food bank if they're facing food insecurity or they're facing housing insecurity and stuff like that. As far as providing basic services, so I included this because it really depends on what you would require from your CHW. So in the schools, right, you have your school nurse who would already provide these basic health screening services to students, right, if needed. And really, it depends if you'd like to hire a CHW to also take on these roles to sort of take off that workload from the nurse, or if you'd like to augment that service. Um, they don't necessarily make call it diagnoses or anything of that nature that requires licensure or specific licensure. But as far as basic services go, with recording height, weight, blood pressure, and giving those data points over to the patient, as well as the requisite health services that need that, that's something they can do, and that's really dependent on what you require from your CHW. Other things that fall within the outreach role, those CHWs can follow up on health and social services encounters with individuals, families, and community groups. And the really nice thing about the CHW is they aren't necessarily tied to a school setting or an office setting or just a specific clinic. Community health workers are encouraged and often go to places that make the patient or the client feel more comfortable. So if that means home visits, if that means visiting them at the library, the place of work, worship, wherever they feel more comfortable, that is a service that the CHW can perform. Education is a really big part of the community health worker role. CHWs are tasked with increasing health literacy among their patients and clients so that the goal eventually is to get patients and clients to start thinking about their health more, start becoming more aware of their own health literacy and improving it, and then getting to a point where they can start advocating for themselves as patients and what they would really need. So, health promotion, disease prevention, those are all important. I would like to note, though, that despite all these education and services that the CHW provides, it's not a replacement for other services. So, for example, while a CHW may provide individual support and coaching, right, mental health help, and uh, basically meeting the patient where they're at, this doesn't constitute as a proper replacement for therapy or really anything like that. So, not to say that CHWs can completely take over the role of therapists or physicians or anything like that. This is more just so it's more of a supplement, basically a service that can be provided to the patient as an addition, or if support is needed prior to them making a connection with a therapist. And then, as I mentioned before, when it comes to patient self-advocacy, really the education is there to help motivate and encourage people to take care of themselves and to seek out these different services as they become aware of what their specific health needs are and as they become aware of what resources are available within their own community. Sometimes people need help figuring out and coordinating where to visit and who to visit. So CHWs offer coordination services as well. They make referrals and provide follow-ups with patients and their connected services. The really big thing is medication or treatment plan adherence. And for some patients, especially younger ones who don't necessarily understand the necessity for sticking with a plan and being consistent with it, it can be really tough. So this is where CHWs can come in. This is where they would initiate coordination between the patient and the service, as well as give follow-ups to see, okay, well, is the patient following through with their medication adherence or their treatment plan? Yes or no? Okay, if they're not doing what they're supposed to be doing, how can we modify their behavior, or how can we modify their day-to-day schedule to fit within this plan, right? So, for instance, let's say you have a patient who needs to have a certain amount of pills every day at a certain hour. It could be as simple as connecting or getting one of those like calendar pill bottles, I guess boxes for the patient, or coming up with something that's a little more tech oriented. So setting up, helping them set up alarms for when to take the medication, having them set up calendar reminders to let them know, hey, like I'm supposed to take these pills at this time, so on and so forth. And then last but not least, advocacy. So the really neat thing about CHWs is with advocacy, it can really go as far as going into policy advocacy on a government level, if you want to call it that. So it can go from as low as, advocating for basic needs in the local communities, so advocating for the continued funding for food banks and continued support for housing and transportation services, all the way up to larger level policy advocacy based on data and based on feedback. So for the school system, really, it'd be more so on the local level, right? Basically advocating and educating parents and local organizations to band together, but you can really take it up to really being an advocate on the legislative level of the union. So with CHWs, there's been a lot of talk recently about how skilled should a CHW be. When it comes to workforce in the healthcare field, especially, we see a lot of cross training and a lot of responsibilities and roles being expanded for um, different positions, which for a lot of us, we don't necessarily think of as a horrible thing, right? If you had let's say, a community health worker who's also a phlebotomist, who's also a dietitian, who's also a teacher and a registered nurse and all that, right? They wear many hats. We often think of it as really nice as having someone who's so talented and extremely multifaceted. On the flip side, there's been an argument for CHWs to be very siloed. CHWs should be CHWs. They should focus on their roles, and they shouldn't touch the other roles of nurses, or phlebotomists, or case managers, or anything like that. They should just focus solely on being a CHW. Really, I don't ascribe to either belief. It really would depend on the employer themselves. And really, I would invite you to really have that conversation about how you would like to use your CHWs. Me personally, though, I would say that you should be careful about how you would expand the CHW's role, right? If it's more of a, hey, like we can't really spend as much, or we don't have enough funding to support multiple staff in this role, understandable, right? You can cross train registered nurse to also do CHW practices as well to save yourself on staff. But just be aware that there is a higher possibility of burnout based on how many roles or expanded responsibilities you keep tacking on to the person. As far as the state of Nevada goes, we have had the fantastic privilege of getting CHWs into the NRS as a Medicaid reimbursable eligible position. So they have their own Medicaid reimbursement schedule, and it's all based on patient education and patient training. And at the bottom, there's also a telehealth reimbursement that's mainly for CHWs who use telecommunications, so like FaceTime, Zoom, Google Meets, Teams to meet with a patient face to face who is geographically different from that CHW. So as far as the state of Nevada goes, there are covered services and non-covered services as detailed with the Medicaid service manual. At its core, all the covered services related to patient education and patient training. Anything that deviates outside of the covered services for a CHW are not Medicaid reimbursable. So those services can't be reimbursed. However, CHW services should not solely be focused on covered services or non-covered services. I usually would advise that CHWs do what is necessary to help the patient attain their desired health goals, which is ultimately, at the end of the day, the ultimate goal, right? Is to help the patient however you can. So whether that's through covered services or non-covered services, it would really depend on that CHW and the plan of care that they would prescribe. And as of 2017, there have been a series of studies on CHWs as a role and their impact on return on investment, both economically and health-wise. So as far as the economic impact goes, back in 2017, the University of Nevada, Reno made a meta-analysis study on the impact of CHWs as it relates to Medicaid reimbursements. And what they had found was, on average, CHW interventions return about $2.47 on average for every dollar invested into the patient, right? So for $500 billion spent on medical expenses in the US, the cost saving is pretty palpable, right? And we could probably extrapolate this data to other states as they make their own studies. But so far, the findings have been pretty positive when it comes to CHWs and their roles. And this isn't necessarily just on Medicaid reimbursement as well. This is also on costs delegated to the patient themselves, right? So, for example, costs associated with getting medicines. You have apps like GoodRx that some of us might be really familiar with, some of us might not really be familiar with. But GoodRx is an app on the phone or on the computer that basically shows different medications with different price points based on out of pocket or insurance covered prices. And if patients aren't familiar with GoodRx, right, they could be spending way more out of pocket than necessary. With CHW intervention being, hey, like download GoodRx on your phone, that that cost associated originally with out-of-pocket spending for medication has the potential to be significantly less, right? And it really depends on what the intervention is and what that specific case scenario is. But for the most part, on average, CHWs have a pretty positive economic impact. Not to mention having a positive impact on health outcomes as well. But health literacy improvements have been found pretty countrywide, from Florida to Texas, Connecticut, Illinois. CHWs have been found to consistently improve health plan and medication adherence among clients. They've been proven to increase patient advocacy when it comes to figuring out their health needs and what resources are available in the community. And they've also been found to help increase health literacy when it comes to things like vaccine confidence, medication confidence, and different myth busting of certain illnesses or certain health outcomes like bird flu. And so that brings us to the end of my presentation. Thank you very much for listening. I sent Erica a copy of the slide deck. So if you would like a copy and you still haven't received it, she can probably share it with you. But if you have any questions, please feel free to drop it into the chat. I see a couple of questions there. Let's see. How would agency pay for the CHW? Is CHW spending time providing non-covered services? So that is more of a, I guess, fee for service model. Unfortunately, there really isn't a way to cover CHW non-covered services through Medicaid unless you have a grant that is specifically providing the payroll for that CHW, or if you have a fee for service model already implemented. So for instance, having, I don't know, like a $20 fee for every hour spent on that patient. It really depends. And unfortunately, for state or local agencies, it's mainly grant funded. Fee for service is more something we found in private practices. So, for instance, like if a CHW is self-employed or if they are in a conglomerate of CHWs, there's probably a fee for service model set somewhere in there for rated funding. Costs related to that. Okay, yeah, that's it. Does anyone have any questions they would like to ask or like to put in the chat? Yeah, exactly.
That was a great presentation. I really appreciate that. Um, I was wondering if there's evidence that individuals with stronger local ties, such as long-time or multi-generational Nevada residents, are more likely to stay in their communities after training. And if so, how do you weigh the return on investment of recruiting those individuals versus recruiting from outside the community or out of state?
Fantastic. So funny enough, that is something High Sierra AHEC and the Watson Institute are still trying to figure out. As far as the likelihood for someone to stay local within their community, unfortunately, we don't have any data that would definitively say, hey, someone from Winnemucca will stay in Winnemucca 70-80% of the time, right? We're still trying to figure that out right now. However, as far as return on investment or bringing someone in um, outside of the community, realistically, the ROI in terms of economic costs is the same. The only difference that you would realistically have between a transplant and someone who's local is patient rapport and local knowledge or local insider knowledge. Uh, these things are really hard to quantify, frankly. Right, because like I don't know how you would ascribe a number value to how much you trust someone, but from what we've seen, right, and you can like think of it like if you've ever driven down the highway and you see those billboards of like, oh, don't make Nevada California, right? Um, I don't know how many people you've interacted with who have said like, "Oh, I don't want to interact with you because you don't know what you're talking about. You're not from Reno because you're from California." Um, I anecdotally have only seen or met maybe like 3 or 4 of those types of people. Um, so really, this push to have someone local to the community is based more off of, well, if they're part of the community, theoretically, they would be more familiar with the patients that they serve, the neighbors that they serve. So that whole idea of okay, gaining patient rapport and trust and respect, it gets significantly truncated, significantly what do you call it, fast tracked. But as far as all those other measurables, we're still trying to figure that out.
Thank you. I appreciate that.
Anybody else have any questions? Yeah, Priscilla.
I was just gonna say a comment. I lived in Vegas for 24 years, and I've been a CHW for a few years, and I can just testify or say that in my experience, we always get either refugees, we get people from other states, either from the East Coast, from the West Coast, and I think it depends more on the initiative of the CHW or the willingness to help from the CHW, because I have helped some people that are just coming in freshly 3 months from either the East Coast or wherever else, another country, and I just did some very simple help and guidance. And that could be done by also someone that just has initiative and willingness to find or assist the person. So I think it also depends on, again, on the initiative and the passion of the CHW and the willingness.
Yeah, absolutely. And as far as willingness goes, part of that is also this belief of, um, I guess, Priscilla, could you comment on this? Sort of like part of that initiative of willingness is also tied to um, the belief that your role is being respected, or you're being adequately compensated for those services if you try to do additional outreach or additional planning for patients. Could you comment on that by any chance?
Sorry, could you repeat the question? I don't think
Oh,
I understood.
yeah, like I'm just really curious about that. So, like, when it comes to CHWs feeling the need to go above and beyond and having that initiative to assist patients outside their scope, um, is it more of a case of they'll do it when they feel properly compensated for those services, or they feel like their role is respected, or is it simply just a person to person basis, like from the goodness of their heart, or something like that?
I do feel, because I've been on both sides. I've been the provider for services, but I also been like case management now as a CHW, and I feel that for me, what works is knowing that you're getting the opportunity. A lot of people say, yeah, you carry many hats, but also having the opportunity to learning skills, because this is very valuable. It will definitely carry on to your professional career, and I think it will be very helpful. So I think that's my mindset above all.
Appreciate it. Thank you. And then Christine, are tribal CHW reinvestment or reimbursement rates the same as non-tribal? Yes. So under the Medicaid Services Manual, no matter what the setting is, whether it's tribal or non-tribal, nonprofit or for profit, the Medicaid reimbursement rate still stays the same. Now, the overall compensation rate may be different because there may be additional grants or federal financial funding that's available in those settings as opposed to non-tribal. But from what I have seen, that hasn't been the case. It's mainly just been um, whatever grant is available. That's what the tribal CHW is compensated with, on top of what is determined by the Medicaid Service Manual. How many CHWs are, so Monica, how many CHWs are currently working inside a school building, or are they working at High Sierra AHEC's office? CHWs invited to work with students, families in our schools. Our CHWs in all 13 or 14 of our rural schools? No, actually. So, okay. First question. So, CHW is currently working inside of a school building, or they work at High Sierra AHEC. We don't have any CHWs on payroll. We are simply just a trainer, and we help connect students with potential employers or host sites that really need that CHW services. As far as how many CHWs are currently working inside of a school building, I don't actually have that data. Um, as far as I am aware, I don't believe there are any CHWs in Washoe County. I think I remember checking this though, but if there are around 4 schools in Clark County that have a CHW on staff. Um, as far as a statewide data, I haven't been able to find that, unfortunately. And then are CHWs invited to work with students and families in the schools? Yes. It really, any student, individual student, or any family that has medical or social determinant of health needs that a CHW can address, CHWs can work with those people. But yeah, thank you, Erica. Yeah, I believe Erica would have better data and metrics on those. Okay, any last questions before we conclude this meeting? No. Okay. And if you do have any questions, oh, I can't interact with the chat. Okay, cool. So once again, my name is Andrew. If you have any questions, please feel free to email me. It's Andrew at highsierraahec.org. There are 2 A's, like High Sierra and then AHEC. Please feel free to email me anytime, Monday through Friday, 8:30 to 5, with any questions you might have after this meeting. Thank you, Eric. I appreciate it. But if I don't return your email within 24 hours, if I don't return your email immediately, I'll try to return it within the next business day. I don't normally check my emails on the evenings or on the weekends, but I try to answer everything as timely as possible. So thank you all so much for your time and consideration. And thank you, Erica, for inviting me to present.
Thank you. Have a good rest of your day, everyone.